Good morning, everyone. I'm Dr. Kuldeep. I'm presenting a topic on small cell carcinoma mimics lymphoma on CCT chest, a case report. Introduction. Small cell carcinoma and lymphoma both have varied clinical radiological profiles. Small cell carcinoma has aggressive progression of disease. It constitutes 15 to 20% of all the lung cancers. It mostly presents in the third decade and fifth decade. At the time of diagnosis, approximately 30% of the patients with small cell carcinoma have involvement of mediastinum and lung parenchyma with supraclavicular lymphadenopathy with 2 years of survival rate. Lymphomas are aggressive lymphoproliferative disorder with a 50% of mediastinal involvement in Hodgkin lymphoma and 15 to 20% of non-Hodgkin lymphoma. Both have bimodal age of distribution and involves early 30s and 50s. Aim and objectives. To confirm the diagnosis of small cell carcinoma lung in patients suspected with the lymphoma on CCT chest. History. Patient is a 50-year-old male, known case of COPD and presented to Department of Pulmonary Medicine with chief complaint of left-sided chest pain for 6 months, cough with expectoration for 1.5 months, breathlessness for 1 month, hoarseness of voice for 1 month. There was no history of hemoptysis. Patient is a chronic smoker for 35 years and smokes around 10 to 12 BD per day. Clinical findings are chest wall nodule, left supraclavicular lymphadenopathy, tubular bronchial breathing in left infraclavicular area, and bilateral diffuse bronchi. All the routine blood investigations were normal. Chest X-ray suggested of left upper lobe collapse with left midzone opacity, mediastinal widening, bilateral hyperinflation, and left-sided pleural effusion. All the findings are suggestive of lymphoma. CECT test was done for this patient. It showed heterogeneously soft tissue attenuation lesion involving superior and medial mediastinum with bulk on left side. The lesion is seen extending into anterior chest wall on the left side through first, second, third, fifth, sixth, and seventh intercostal spaces. There is loss of fat planes, and clearly it is seen involving adjacent lung parenchyma along with mediastinal border. This is soft this soft tissue lesion is seen encasing the mediastinal vessel, including ascending and descending thoracic aorta, arch of aorta, brachycephalic trunk, left subclavian artery, left common carotid artery, main pulmonary artery, along with right and left pulmonary artery. Bilateral subclavian veins, superior vena cava, causing a marked narrowing of left pulmonary artery and mild focal narrowing of right pulmonary artery, comprising bilateral subclavian vein and superior vena cava. It is also seen in casing and causing the narrowing of left main bronchus. Emphysematous changes are seen in bilateral lung parenchyma with left-sided pleural effusion with left supraclavicular lymphadenopathy. All the findings are suggestive of lymphoma and COPD. This is a chest X-ray showing a left upper lobe collapse with mid-zone opacity with mediastinal widening with left-sided pleural effusion and bilateral hyperinflation. CECT chest showing a mass lesion encasing a major blood vessel both ascending and descending thoracic aorta and pulmonary vessels. This is a chest wall nodule in this patient. Pleural fluid analysis was exudative in nature and cytology was negative for malignant cell. Ultrasound abdomen was normal for this patient. Sputum for cytology was negative for the malignant cell. FNAC chest wall nodule and supraclavicular lymph node was done. It made two differential diagnoses. First was metastatic carcinomatous deposit and second was lymphoproliferative disorder. So bronchoscopy was planned and it was done, and findings of bronchoscopy was a whitish growth present in the left upper lobe bronchus, partially occluding it. So bronchial biopsy was done from the intraluminal growth. Discussion. Sometimes at the time of presentation, both tumor have radiological picture due to same radiological picture due to aggressive nature. When the extent of disease is both in mediastinum and lungs with pulmonary vessel involvement, then it is difficult to differentiate between two. Clinically, chest wall nodule denotes more towards bronchogenic carcinoma. When FNSC of mediastinal mass was inconclusive and could not differentiate between two, bronchoscopy guided interluminal biopsy was done from the growth, which confirmed the diagnosis of small cell carcinoma and was positive for CD56 tumor marker. Conclusion. Small cell carcinoma and lymphoma Both are challenging to diagnose. When there is a discrepancy in clinical radiological profile, biopsy should be done to confirm the diagnosis, and immunohistochemistry will help to label a diagnosis of small cell carcinoma. Thank you, everyone.